Well, hello, everyone. Thank you so much for joining me today. I've got a very special guest that's joining us from the United States, and we actually met many years ago at a Myofunctional orthodontic conference, and we were just kind of reminiscing on in Chicago. And it's been many years since we've talked, but I'm really excited to have her on because of the way she brings a really amazing view to the world of orthodontics. She's an orthodontic specialist, but also to how we start to look at the growth and development of a child, and maybe a different lens on crooked teeth. Dr. Catherine Murphy, thanks so much for joining me today.
My pleasure. Thanks so much for reaching out.
Yeah, I've been following your work for some time, but we kind of connected back in Chicago. It was at a conference there was a lot of kind of people that are in this kind of space, and we're just talking about how it's kind of changed a lot since then. And so I've been really interested to dive into your work since then, and your kind of view of the way that we can really change a child's life through interventional orthodontics. Tell us a little bit about your journey into this, because we were just talking a little bit about how your perspective was changing, and what was some of your personal experience as a specialist orthodontist in starting to shift your view of the world?
Well, so what I love so much is that being able to meet you back in 2017 and Dr. Roger Price at that same conference, I was there looking for answers I was not getting from my orthodontic specialty. And really, it was getting very frustrating for me as a specialist that the answers I was given for problems, like I was in my practice at that time, I was head of the orthodontic department of a pediatric ortho office. And so when I was seeing impacted second molars at the age of 12, they were trying to say, oh, well, you just see it because you have this unique population, or because the population of that town. And I was getting really frustrated with that. And I was getting frustrated with the number of tongue thrusts I was seeing, and basically just brushing me off. Or I was seeing a lot of cases where there was spacing. And so much of my residency was based off of crowding and how to deal with crowding versus excess spacing. And so one of the answers was just to put a TAD right in the central here and bring everything forward. And I'm like, well, but why am I seeing these cases? These cases that are supposed to be rare, but I'm seeing them every day in my practice. And my practice wasn't huge. I've never been one to want to see 100 patients a day. I've always really liked to get to know my patients. And I had very few cases that were more routine for an orthodontist. And I say that because as a specialist, I don't get the cases that just have a little bit of crowding. I get the more complex cases, as I should. And it was very frustrating. I mean, I went to the quote, the best orthodontic CE. I'm always been a CE junkie, and the answers weren't coming. In fact, one of the conferences I went to, and I'm not going to share the name, I will just say it was supposed to be the best of the best. They were laughing at an orthodontist he put himself out there saying extracting teeth is just as harmful if you went and you saw a crooked toe and you took the crooked toe off the person's foot. They were laughing at this, at the guy saying, this is insane. Why are we looking at extracting teeth to fix? And so I'm among these leaders in my specialty, not getting the answers, having people laugh at someone who would be so bold to say, why don't we look at things a different way? And I was frustrated. So finally, I always love to give a shout out to Dr. Yulia Pinskaya, who at a leadership meeting, we're the only two orthodontists there, she challenged me and said, why aren't you doing more for your phase 1 cases? And I said, I love phase 1. There's very few orthodontists, my father's an orthodontist too, that really love phase 1 or interceptive treatment or early treatment, various names for it. And she's like, yes, but you're not doing enough. I'm like, no, I don't think you understand. And she's like, you got to question more of why. And you've got to look at the why. We went through the same training. I think she was 2 years behind me in the same orthodontic training. And she's like, did you ever challenge them? I'm like, no, I was a good student. Why would you challenge your instructors? When I did, they didn't, they weren't receptive to it. So she actually, I then asked, I'm like, okay, fine, send me information. A deluge of CE that was not truly orthodontic related, many of which actually wanted to take me to your country of Australia. And I'm like, are you insane? To spend over $10,000 for a course going to Australia. And now here I am traveling all around. But basically, I got there because I did start to ask more of why. Why is this going on? And again, the background I have, I had one of the elite orthodontists trained in Harvard, so much genetics background, and would talk about the genetics of these cases. But let me tell you, there's still what you're trying to chase with genetics. You can keep chasing that unless you start to look for more of the underlying reasons. You can look for these genes and these genes, but let's find out why these genes aren't being expressed, right? So that's how I got here. But I got to that 2017 meeting where my husband actually brought our son to it so he could be further evaluated because someone had mentioned he might have a lip tie. And Yulia's myofunctional therapist, Lisa Leahy, was there at the same conference and evaluated Patrick and got the course going of getting him treated, because I as a dentist, as an orthodontist, was very cautious about revising any tethered oral tissues in the mouth. I can go more into what got me there as a mom as we continue to discuss, but that's what was so lovely. Your description of the Pottinger's cats, the 4 generations, that was really the first time I had heard that, which I'm sure you probably share often with your patients. And just, I really enjoyed being challenged. And I have fallen in love with orthodontics and dentistry because I'm talking to so many other professionals outside of dentistry about the things that influence my patients.
It's so interesting, isn't it? You talk, orthodontic training is, it's one of the highest levels of specialty. It's one of the most difficult, mechanically challenging, practices, but there is quite a lot going on. I think with dentistry in general, we get very zoomed in, don't we? We get our loops on, and we really kind of get focus on the minutia of the teeth and the and really looking at the mouth, which may be something a little bit more kind of cosmetic focused. But there seems to be this theme that there is more going on with our patients, and that that if we start to kind of dig deeper, you suddenly start to open up this whole world that the crooked teeth is telling us something. And you spoke about. I remember actually at the conference you spoke about impacted second molars, and this is a significant presentation in a patient to have an impacted 12-year-old molar. And there was a number of people at the conference at the time that were talking about this was happening more, and that's an alarming thing that our profession really should be kind of discussing and thinking about. And these kind of things, they start to change our perspective. But I think probably the most powerful one is the journey of a parent, right? Where you actually see, the changes in your child itself, and then it starts to kind of tweak some questions that you see in patients too. So, what did you you notice in your child that started to kind of bring on these questions?
So, my son, I'm going to give a little bit extra background, just because, for those that listening, it really doesn't matter what age you were at, because I feel like there's many things that go into motherhood, parenthood. I was labeled as being a geriatric mom. Those that are having kids younger, they can be stereotyped or labeled as a young mom. So in general, labels just really confine the conversation between the provider and the patient. So my son was really struggling to sleep. Breastfeeding was a huge challenge, and he wasn't thriving. Now, we had gone into the practice 4 times within the first month of life. The first time was actually just days after, because I developed an infection in the hospital, and he was put on IV antibiotics. And as a new mom, I wasn't thinking clearly. I know when I prescribed antibiotics when I was a general dentist to my patients, I would always talk to them about the gut, right? I didn't think about my little baby. And he was born at the elite Chicago hospital, and no one talked to me about his gut health. Okay. The pediatricians didn't. They just said once he was failing to thrive, that he could not leave the room until he finished the bottle of formula that they gave me. There was no discussion about my desire to breastfeed him and what was going on with that. When I talked about his loud breathing, she simply said, "Some kids are just like that. You're a geriatric mom who worries too much. Go home and enjoy your child." So thankfully, I was at a infant massage class where the pediatric PT, physiotherapist, physical therapist asked if she could show me some stretches. I'm like, sure, but I was beyond sleep deprived. And so I'm like, Mom, can you please record these? And I showed them to my husband. I'm like, I don't really get it. I don't know, but she says it could help. So let's just do these. And for those that can see, I just happened to have this for my water. His head was always in this position. So he was always tilted. If you look to all the pictures when he's at the pediatrician's office, he would always take pictures. He's tilted the same way each time. No one talked to me about torticollis, which is the tightening of the neck. No one talked to me about that could affect the breastfeeding, his tummy time, his sleep. And when I asked for the referral for the physiotherapist, the physical therapist, to give him a full evaluation, because thankfully my lactation consultant, love to all lactation consultants out there, she's like, I really feel like you should get a full evaluation. And I said, okay, great. So we started at 6 weeks old for him. But the pediatrician told me, I'm only going to write the referral because you're a doctor. Her husband was an orthodontist in this area as well. She's like, it's not going to help. However, I am one of the proudest things I have in my whole life, degrees, whatever. I am so proud of putting together a team for my son, but ultimately putting a team together for me, because I wasn't strong enough in my advocacy for my health, that it took my son's health to really be like, oh, enough is enough. I know my body better than any practitioner. I know my son better than any practitioner. And if my input isn't being heard, I need to go elsewhere. So that's one of the biggest things. What I love, Stephen, about what you do is that it puts a lot more on the patient to be more in tune to themselves, and that every provider should be listening to their patient. So that's the bare minimum of my son's. Like, if there's anything that you could take away as me being a practitioner and a parent, is that I learned the importance of true embodiment of your body wants to be healthy and that your provider should support that. But also, I'd like to really say that how you approach it, so that it doesn't sound like it's being from Dr. Google, because we all have biases, right? I love that the state that I practice most in is Illinois. We have it, I think it's every 3 years, we have to take an implicit bias continuing education course, so that we can acknowledge that we have this, how we can work through it, how we can be better providers by it. All of us do this. So having a clear conversation of, hey, this is what I have observed in my child, in myself, whoever you're advocating for, and I need your help. Because the provider should be there to help your body. The provider themselves is not there to heal your body.
I think that's a really good point to bring up, also to the difficulty that a new parent goes through in, this discovery of how to kind of, raise this baby that they, that really you don't get. It's very hard to get good information on what happens, and every baby is different. So there is a lot of parents out there that are just kind of asking a lot of questions that probably aren't being met. On the other side of it, the from the healthcare providers, they see a lot of these things. So it's like they'll often be kind of, maybe a little bit disconnected from each and every parent's kind of, maybe wants and needs, or kind of, specific observation, as you were noticing with your son. But then it really is on the patient, the parent, to kind of, keep going down that track, because in the end, as you say so well, that we are our own advocates for our own health, and the intuition of a mother, and the patient themselves really is a powerful one that we should be following. So it's a funny kind of relationship there that I think a lot of parents are finding themselves in now. What did you find as this, this obviously kind of sparked, an interest for you, that there was more going on, that you had to kind of investigate deeper. What did you notice with your son as he grew up a little bit more and he started to get his baby teeth and so forth? And what did you observe as an orthodontist in terms of his development, and things that you were noticing that were maybe, intervenable with?
So the main thing from the beginning, because of his loud breathing, was how often his lips were apart. And so it's really vulnerable for me to share this, because orthodontics is the specialty of growth and development. However, orthodontics, once you learn the true growth and development, that's not what we use every day. So for me to say, hey, my profession, my specialty is growth and development, yet I'm seeing my son as an infant with open mouth. And there was just enough of me to know, like, hey, something's not quite right, but to not fully remember and understand that the tongue should be up at the roof of the mouth, that my son is not going to be regulated, be able to sleep well if he's not breathing through his nose, and there's something wrong, and that it is not just the tongue itself, but that it's connected to everything, and to really look at what I'm seeing in the mouth really connected to the whole body, which is now what I get to fully look at when I'm with my patients. Unfortunately, like you said, once we're in dentistry, everything goes back to the teeth. We learn the whole body. We learn how it's all connected. We learn that one thing is going to affect another, but then ultimately we are trained to then provide what our patients ask for. And before, I didn't have patients asking, hey, did my son's lack of breastfeeding lead to his malocclusion? Now I have patients that are like, oh, I realized that my son, daughter, my child didn't breastfeed. It was challenging. I was told it was my fault. Then we were on the pacifier till 4 years old. We had bedwetting till 7. I think this is all related. So it's much more change where some parents are putting that together, which is great. But I also love that I can help that process of especially alleviating parents when the breastfeeding challenge was put all on them, or the sleep challenges was put all on the parent. Like, oh, well, you're not doing this right for your child, when it was really your child needed help. So to go back, what was the actual question? Because I can get off a little bit on this. Oh, what did I see with my son? So the open mouth breathing, that's the number one thing I really will ask patients to look at. I have seen young ones when I had my own private practice. Now how I practice is a little different. I'm in other people's offices, but I will ask any parent that reaches out with my mentoring, look at how often the lips are apart. How are they eating? Then with the primary teeth coming in, is there space? And sometimes when they smile, you can see the tissue falls really deep. That's where then you get other practitioners involved. But I can help with what you look for. If you are not seeing spacing between the primary teeth, let's go get you to a functional dentist. Let's get you to a holistic orthodontist. Let's get you with a myofunctional therapist. Let's get you with your collaborative team. My son's collaborative team, since I said how proud I am of it, the team involved myofunctional therapist, a holistic physician, chiropractic care, physical therapist, then speech pathologist, and occupational therapist, which sounds overwhelming. But let me say at this point, and I'm sure I'll say it again, is that addressing it when they're little, when you first see it, and when you're first prepared as a family to work with that, that's the right time to do it, when you're feeling that, rather than kicking it down. Because there's so many products out there that can kick the can down the road, and it doesn't get easier. Now, that's not to say for families that were like, oh man, I missed that window of opportunity. You didn't miss it. When you are ready, the time is right. Because as you spoke with parenthood, you might have noticed it. And if you didn't have all the support systems to do that at the time, it wasn't going to be successful. Because it can sound overwhelming to be talking with a dentist, an orthodontist, a myofunctional therapist. You might not even know what occupational therapy is. But when the timing is right, that's when it's going to be successful.
There does seem to be an element of guilt coming in for parents now that are kind of looking at, stages of their kids' life and saying, oh, I can't believe I missed this. But I mean, the reality is we're all learning. And I think that's a really good point to say that when the timing is right for you and your family, that's the right time. There is no, don't kind of dwell too much on the past, because it is a difficult thing. Like, parenting is such a hard thing. You can only really, one thing I find with patients is we try to focus on one thing, because parents are just so overloaded and it's so overwhelming. And when you put too much on, it's like sometimes it all just kind of falls apart and nothing happens. So it's like, little steps, and, we'll get there. Like, we identify these things in kids, and then we can move forward with a positive path and plan. So I think that's a really kind of important thing for parents to know, because it is such an overwhelming area. And one of the things that
oftentimes, sorry to cut you off, but in dentistry, oftentimes, and maybe it's different in other countries, but oftentimes we are taught to kind of protect ourselves in our work, that we're like, oh, if only you would have come sooner, I could have given you better results, whether it's from a crown, from a tooth that cracked and they waited, or in orthodontics, they come in at 14 and you're like, oh man, I could have given you a better result if you'd come in at 7. We need to realize as dentists, or as any providers, that we're doing that to protect ourselves, and to let go of that. Like, it's very much taught. We've heard I've heard my mentors, I've heard other mentors say that. But part of my care, the compassionate part, is it's not about me. It's all about them. And they couldn't have handled it at 7. They didn't have the background then. So for any provider, understand that we try to protect ourselves because we want to do the best, but we will give them what they need, because now they're ready.
Yeah, it's a great message too. And like any healing kind of process, is always, hopefully paired with the practitioner. So that kind of connection, that kind of, understanding that there is, there's compassion there, is a big part of that, maybe some people do miss in certain situations. But with the growth and development side of things, there's also this story that kind of keeps going back, doesn't it? It keeps going back to kind of, pregnancy, conception. There are many factors that seem to be influencing how our children grow today. And so you talk to both practitioners and patients about this. Tell us about this growth and development journey, and what you've noticed as the inputs, and what people should be thinking about maybe earlier to kind of help this kind of pathway moving forward.
Well, I think it would be ideal for the first dental visit to be in utero. And I would love, number one, I understand it's challenging, at least in the United States, to even have a visit before they turn 1. So I understand me saying it should be in utero is a feat, but the more practitioners and parents that hear this maybe can help get that change going. But also how we care for the mother, And whoever's going to be that mother supportive team gets to be changed, because there's such an influence in what we eat. So thank you so much for your dental diet book. I think there's so many books that anyone that wants to be a parent should read beforehand, because life doesn't get easier when you're a parent to find time. So if there's 2 books that I could recommend prior, it would be The Dental Diet. And I'm not just saying that because I'm on your show. I have you on my resources page for ages, and Breath by James Nestor. If you can read those 2, there's many more before you're a parent. It's going to help then decide even what your prenatal vitamin is going to be. Here in the States, the first OB visit isn't usually until 8 to 10 weeks. And there's huge embryological development that's going on that can be impacted by how the mother is sleeping, especially what she's eating and how she's breathing. So we're struggling with this rise in so many conditions in our children, but we need to look at the environment that the children are being grown in. And we need to look at the mother and her overall care, not just her, heart rate or her blood pressure, but truly those prenatal vitamins with having folic acid versus folate. And I will tell you, even the top providers, because I challenged with my second child. I'm like, oh, so this one it's folate. There's no folic acid in it. Is that okay? She's like, well, it's supposed to be folic acid. And so even challenging that, and that's a whole discussion. But for anyone who's thinking about becoming a parent, please investigate the difference between folic acid and folate, because there's a high percentage of women that don't even know that they have this gene mutation, the MTHFR, and then they have a problem with methylation, and they need to have folate versus the synthetic folic. And folic acid is actually, at least again in the United States, added to many grains. So a lot of crackers that perhaps the mom is eating when she's not feeling well, because if she's experiencing nausea, there's so much that we could prep for those early weeks of crucial development for this baby and the mom. So my view of the first 1,000 days is, let's actually prepare the mom and prepare her that this is to give more honor to what's going on, that this should be a time period of, it's such a, I don't want to get too spiritual on it, but to give more honor to that process and how this baby is developing is also based on that mom and where she is with her nervous system. If she's nervous and not getting good sleep, and she's very shallow breathing, that is going to affect the baby. And we are seeing our children not being, actually, I'm struggling with the word that I'm looking for, and I use it all the time. Our children don't have their nervous system regulated. And then we put them in environments that are really challenging to them. And then we feed them foods that are really challenging for their bodies. And then we're wondering why there's so many conditions and that there's no easy answer, because it goes all the way back to even how the mom was treated.
I completely agree. Like, there seems to be this gap between, like obviously there's family planning, but like there's really not a lot of support for, young families that are, in that first space of having children, or, any families that are having the first time parents that are going through the process of having children, right? And that there really isn't a kind of a process to kind of onboard people, because it's such a big change in your life, and there's so much going on. And now, as with looking at the orthodontic growth of a child, we see that it is influenced by these early phases. And you mentioned folic acid, and potentially the links here between the floor of the mouth and how it develops in those early phases, which you were talking about. Hey, there's not often examinations then. But this is when the child's jaw is growing, the separation of the tongue and the mandible all has happened by week 12, right? So it's like there's significant things happening, and the things that will reverberate through a child's life, if we pay attention to it. And so I like that idea of an earlier exam in the womb, right? That actually makes a lot of sense, because you can kind of see these retrognathic mandibles sometimes and you can kind of start to plan and understand maybe this child will be challenged with their airway, because we see this a lot now, that we see babies that are just challenged, and it is a difficult space in these early phases to actually to kind of facilitate and guide growth. But if we understand it, it becomes a lot smoother.
And to help understand with feeding the baby. And there's controversy of how breastfeeding is looked at, but if it's actually addressed of, this is what the baby, it's designed, the breast milk is designed for that child. And then the bottles, the squeezy foods, the baby-led feeding, all that needs to be discussed before a mom is on some mom chat group. And some chat groups are great, but some they don't come with a lot of support from what's really needed. So I'm all about the support groups, but also you have to find one that resonates with you. But we need to talk to the family about how this child should be, why tummy time is important, not just because of, oh, I hear it's like tummy time, but like, why, if your baby's struggling with tummy time, what to do. And getting rid of the fear of just overall feeding. I don't know because yours are, you just said the youngest ones are turning 1. The whole process of feeding your baby needs to be brought up. Like, this is truly how your baby's meant to eat, and even down to the right high chair, because we as dentists, we talk to them about what they eat, and like leading to caries once the child is born. But let's talk to it before you're trying to feed this baby, because like I said, it's challenging to have them come in before they're before their 1 year or their first tooth. So let's talk to the mom, prepare her. There are free organizations out there that offer this information. It could be as simple as referring them to, because we need to use the jaw muscles. They need to know early on if something's going wrong, what to do next without that fear. And they're going to be less fearful while the baby's growing in them than when their baby's screaming at them.
Absolutely. And yeah, exactly. Like, so like that early phase is just so busy. It's a lot for people. And so, like, even just surviving that is a feat in itself. But, you're really kind of describing like the understanding that you as a specialist orthodontist, and kind of, having some kind of thought and planning through this as a child grows, that this is a big, potential missing area in healthcare, right? That we really can be plugging in for people, that is so impactful and so important, because we see the impacts down the road as the child, starts to grow and develop teeth, starts to transition into an adult dentition. And so that is something that I think that really can help plug in specialists that are mindful and conscious like yourself, that are really helping parents to understand that. Let's talk a little bit more about that growth and development phase. So what's happening through a child's jaw growth as their kids' teeth are erupting, but then also transitioning into a mixed dentition. What were you seeing in practice, and what are you seeing that kids are experiencing in terms of symptomology with their transition into an adult dentition?
What I'm seeing is so many kids don't actually have the proper swallow. And just yesterday I was talking to a mom, like, you're around your kid all the time, right? So I have an observation sheet in the back of my children's book of things to look for. So if you're seeing your child swallowing, like using a lot of the face muscles or a lot of neck muscles, that they're just so used to their child doing that. But that can be a sign of improper jaw growth. Okay. That can be a sign of poor tongue posture, poor tongue tone, grinding of the teeth. And unfortunately, there's still many practitioners being taught that when they come in with the complaint of grinding that, oh, they'll grow out of it. Really, they just compensate for it. When parents are coming in and they're like, oh, my kids' teeth are perfect. Look how perfectly straight they are, but there's no spacing. Or the kid, the easiest thing for practitioners, if you're new to this, or parents that you come back for your child's exam, if your child is they're calm in the chair, but once you have a practitioner in the mouth trying to clean the teeth or do anything, and the tongue is everywhere and they're trying to be helpful, they don't have the right coordination. So they're not having the right harmony between the muscles of their face, neck, and tongue and their teeth. So crooked teeth are actually such a blessing sometimes because people will recognize the crooked teeth. And so unfortunately, so many patients will get treated only if they have like a crossbite. So the top teeth that should be in front are behind because that's what the parent can see. They can see that that's incorrect. So sometimes I'm very thankful because it's a very apparent thing like, oh, that doesn't quite look right. But if the teeth are together and the parents don't know that there should be spacing, they get missed. I also, if the teeth are really flared, those kids are oftentimes going to be treated because it's not good looking in the parent's view. But there's so many other things. If the crossbite's in the back, the parents oftentimes don't see it. If they're really messy eaters beyond the age of, when they're first learning to eat, that they don't know when they're chewing with their mouth open, that is a sign of a problem. When you start to connect it and you start to connect that if they're always falling asleep in the backseat of the car with the mouth open and connecting that really the crooked teeth are a symptom of an underlying cause. Oftentimes the underlying cause is mouth breathing, but mouth breathing itself is just a symptom of other things going on. So the easiest things for parents to see that I ask them, start looking at how they fall asleep if they're watching TV, if their mouth is open. Then look for spacing. Look for how they're chewing. Look for how they're swallowing. Because again, they don't quite know what to look for with the teeth. So spacing or too much spacing is really the biggest thing. And then when I get to show them, especially the top jaw, just not being forward enough, because then you'll see the like purplish. So some people call it allergic shiners. That term doesn't really resonate well with patients, but you can just say like the tiredness, like did your child sleep well last night? How often do they have this? Because we recognize it in ourselves after we've been without sleep for a while. Our child should not have that. Did that answer the question?
Yeah, absolutely. So the signs that the child's not breathing well, and then connecting into all these orthodontic presentations, like as you say, that the parents are starting to kind of pick up like, hey, like there seems to be something going on with little Johnny's teeth, but then like the link between that breathing and sleep seems to be the one that that the practitioner can really help build that bridge for the parent and the patient, and then identifying that there are influences to how the teeth are growing, which is it's still not common knowledge that the teeth move and that they are a product of our breathing and function, which is quite an important thing for parents to know. You've mentioned the tongue a bit, and so I'd like to kind of compare maybe what we see, because the tongue is identified within the orthodontic specialty as being an influence to malocclusions and the development of the jaw and the dentition and so forth. What do you feel that kind of traditional look at the tongue, and so maybe some of the devices that people use to prevent the tongue touching the teeth, and how can we kind of maybe shape this into more of a behavioral change for a parent and patient? So how is your view on that changed?
Oh, dramatically. I will admit, because I'm very transparent. I will tell people my mistakes. As I mentioned earlier on in the podcast, I was struggling with patients that had tongue thrusts. And so I did, unfortunately, put spikes back behind their front teeth in order to try to avoid them pushing their tongue against their front teeth. And I did tongue crib. So a tongue crib, there were little circles around the back teeth, and then some of them would be really nasty looking. Thankfully, I always use the ones that were kind of little, it looked kind of like 3 little bows to help keep the tongue from pushing on the teeth. And that was before I knew about myofunctional therapy. And so unfortunately, I did use those because that, again, is what was in the literature. I mean, it's in the literature and what was taught. So those that are still using it, they do have the evidence with that. Unfortunately, it's not looking at the true tongue problem. It's just looking at, yeah, you're going to be able to retrain your head. Okay, I won't do it that way, but doesn't mean that you're swallowing properly. And those tend to come back. So with open bites, an open bite means that you don't have the top teeth going over the bottom teeth at all. So there's a space between. That is one of the most typical things to come back because of the tongue. I know one person that's gone through braces 4 times to try to close that with elastics. They try it early when they're younger with that little device I talked to you about, the tongue crib, or the spikes behind the teeth, which I'm so sorry to all those patients I put them on. So sorry to you. I felt bad putting them on, and now I feel even worse. Whereas myofunctional therapy is going to help retrain that tongue, but then where the orthodontic specialist comes in is to actually realize that in most cases, the maxilla, the top jaw, is too far back. And so the tongue is adapting to the improper jaw placement. The top jaw is influenced by our tongue. Okay, so it's different bone than our lower jaw. Our top jaw needs proper placement of the tongue, needs our lips together, needs proper swallowing to be moved in the right direction. So it is very much influenced by those things. Okay, so lips together, proper swallow, nasal breathing. Okay, unfortunately, there's so much looked at just the lower jaw being the problem in orthodontics and not so much the top jaw. So parents, when you're noticing the teeth being opened, and if it's only blamed on a pacifier use, yes, pacifier use can lead to that, but you have to ask why that child was using the pacifier. So it's always asking why and looking at things, and when something just doesn't seem right, to ask. And if you get brushed off, because many don't know that someone as young as 3 can be treated. Now with things like the Myomunchie, you can start with different support appliances at a younger age along with other healthcare providers, okay? They just don't know that. But you can get in touch with those. There is support. We can help you link to that. So with the tongue issues, it's really a lack of looking at where that top jaw is and how the tongue is compensating. It's very rare. You can Google it. I understand it'll come up that there are some people that are born with tongues that are too big. It's very, very rare. Very rare. It is more that the jaws are too small, and that we've had to adapt things for our jaws not having that proper growth, which goes back to not properly chewing from the young age of when you're starting your first foods. Okay. It can be overwhelming. I understand that.
There's a lot to it. I might just bring up this problem because so in early ages, Louise asked, can tonsils cause dental problems? Have you seen this in your practice, Dr. Murphy?
So with large tonsils, again, I go back to the why are they large? Because we know they're lymphatic tissue. They should be large at a certain age, and then they decrease. Okay. So with the tonsils, I would first be looking at how much they're mouth breathing and the influence of the tonsils with that. Also allergies. And I'd be looking at the top jaw again, because if the top jaw is too far back, the tonsils can look bigger. They can be normal in size. So I look at that first. Now, I also very much support that there are patients that come in and they are in such need of good sleep that removing that obstruction is a great first way to get that child to sleep. But I argue that anytime tonsils are taken out, the breathing needs to be retrained. I had too many patients where I asked the ENT, they took out tonsils and adenoids. They were still mouth breathing because I didn't know about myofunctional therapy. So yes, tonsils can cause the obstruction. I would look at the why, and I would also look at where the need is on that patient of getting that obstruction out right away, or seeing with interceptive treatment, looking at the diet, looking at the allergies, if you can address it that way and avoid that surgery.
Yes, it brings
Thank you
up
for that
a
question. Yeah.
yes, it brings up a good point though that surgeries can play a part, but we really need to guide the patient back to function, which is ultimately breathing is this very complex picture of physiology, of growth, of tongue placement, and all of these things come together. I think some of the kind of criticisms of surgery seem to be around when you don't have this team to kind of help the child move and grow and develop after, right? Which is really what the dental office can be. Dr. Murphy, you've helped practices, through your own journey, which has been, such an enlightening one, and one that's kind of, really kind of showed, how holistic orthodontics can be, which is a kind of a nice, it's not a very, it's not often those two terms are put together, but you're kind of seeing that, the practices can kind of change their way of their view of growth and development and early interventions, so forth. Tell us a little bit about this, about how what you feel like the opportunity for is in the dental and specialist office too, where we can help change our patients' lives.
Well, first of all, I want to say that for those that they see all this and it's overwhelming, the first step, you don't have to do all this. If you don't feel like right now you have a myofunctional therapist in your area, again, I can help you find one. But you don't know how to put this whole team together. The number one thing is just to kind of let go of a lot of these ideas. If you see the patient's history, to let go of what we think we might see when we walk into that room. So sometimes it's actually helpful on this first step to then just go in and see your patient and look at the health history later, no matter what the age. Because if you see a child who's 7 and they're on meds, what is going on in your head might be vastly different than what's going on in that family. That family might be so desperate to get this child to go to sleep, to figure out how they can get through school, that they are on meds at the age of 7. Okay. So try to meet that family first, see what's going on. And if you're seeing a child, because most of us have had this in their practice, they're having a lot of cavities, but the parents are like, but we don't eat candy. We look at what they're eating. Look at how they're breathing. We were taught this. We know sometimes we can see the inflamed gum tissues, but sometimes those kids don't always show that way because they can be eating what they think is a good diet, but they need a little bit more education on that, but they need more education on that mouth breathing. So know that you don't have to have all the answers and to let that go. If all healthcare practitioners let go of the thought that they needed to know all the answers that got to their chair, we would be in a better state. So just know, oh, shoot. Okay. Maybe I'll look at the resources page that, you offer, Stephen, or that I offer, like these books that we've talked about, and say, hey, I don't really have the exact answer for you, but here's a good place to start. And with that, to know that so often dental problems, just because we see it in the mouth doesn't mean that we as a dentist have to fix it. And if dentistry would really embrace our collaborative care, working with myofunctional therapists, working with speech language pathologists, we could do more of what we are great at, which is really great dentistry, and not trying to put a Band-Aid on the grinding of the teeth that we don't have a good answer for, because that should be looked at by others. Just because it's showing up in the mouth, remember the mouth is the mirror of the overall health, but that doesn't mean that you, the dental provider, have to fix it. Like, we see the effects of snoring in the mouth, but that's a team to correct that snoring.
Absolutely. And, I think maybe too that the dental office is probably a little bit left out of this whole picture, because patients will go to pediatricians. They might go to the ENT surgeon. But sometimes the whole picture of that oral development is just left out, and really kind of helping to plug that in. Getting dentists to kind of connect with those other practitioners can help as well. And hopefully that's something that we can look at in the future that is a little bit more integrated, so that we're all working together. As you say, putting the team together can be a lot of work on the family and the parents themselves, but also to each individual family is kind of going through their own journey. So it's important to kind of be mindful of that, and just facilitate that, and kind of just be, sometimes you just have to be there for them, right? Sometimes they just need that kind of understanding that we understand that it's difficult, and that we're here to help where we can. Tell us a little bit about where people can find you, and a little bit about how you'd like to see kind of maybe the future of orthodontics, and where hopefully the change is in the future.
Well, you can find me. I'm on many of the social platforms under Dr. Catherine Murphy. So just Dr. Catherine with a C, Catherine Murphy. And I love to connect. So if you want to email, I really like Instagram. So if you can follow me on Instagram there. And where would I like to see the specialty? I would really like to see it embrace what we truly learn, the growth and development. We can play such a role by starting younger, working with more, and there will always be the patients that just want the cosmetic orthodontics, and there'll always be the orthodontists that want to do that. That's great. I think every provider has, there's patients for every provider. Every provider will have their patients, but if orthodontics wants to really make the impact that it can, it will realize that we play a role in our future, and we are seeing our kids are different these days, and to really be accepting of that, and knowing that, yes, a straight smile is beautiful. It's been great to be able to give better smiles, so it enhances their self-esteem. That part is fabulous, but it is so incredible to actually help their growth and development by recognizing, oh, this is not how a child should be looking at 2. If they have all their dentition at 2, we can look then. We can make an impact even younger, depending on what you're comfortable with. We, as orthodontics, we're not trained to work younger than 6 usually, but that can be changed. We should be working more with our pediatric dentists and our general practitioners. Otherwise, I really see our specialty, if we don't do this, I don't find my specialty being very successful if we don't start to embrace that teeth alone is not what orthodontics changes. And I know that's bold to say, and I love my organized dentistry, but we're at a crossroads, and we get to make a decision. And if you really, as an orthodontist, want to grow your practice, you're going to listen to the needs of your patients, and your patients are coming in. And when they're asking for straight teeth, but you can't give it to them because the tongue keeps being in the way, stop putting them on those anterior elastics alone. Stop putting those tongue cribs in. You're going to get very short-term results. And the one thing orthodontists can all agree on is retention and how to keep the teeth. It's a struggle. And the reason why it's a struggle is because if we don't look at the other factors that affect that smile that you've created, you're going to have to keep battling the relapse. You're going to be battling the teeth that went back, the open bite that opened back up, the deep bite that got back to being deep. We have to embrace that what is our most biggest annoyances, which is retention. That's our opportunity of really making our profession better for ourselves. Because I will say, I love going to work now, whereas before it got to be very routine. Like, what am I doing? And giving the most to our patients, giving the most to us and to our patients' overall care. And when we all decided to help people for a reason, You don't go into dentistry where you're working in a small area. You have a lot of pressures put on you. You don't go into it without this, like, you really want to make an impact. And this is what better impact can you make than helping someone have the proper growth and development?
Well, thank you, Dr. Murphy, so much. It was a pleasure to hear both your personal and professional journey. I think that's really important. So, as a change maker in the industry, it's important for people to hear your kind of how you've walked that and how you've kind of thought about it as a specialist and how you've kind of, enacted that change into, both your patients and your own life too. So it's really helped I think for people to hear that. So thank you very much for sharing that and walking that journey yourself. And I hope to continue this conversation very soon, and we'll have to catch up again.
Thank you so much for having me.
Thanks, Dr. Murphy.
Bye.